Hope you can hear me now.
Yes, we can, Nikos. Great. Fantastic. Sorry, we had a little bit of a problem with the lobby. Good morning, everyone. Really happy to be here today and to welcome you all to this very nice webinar titled Scaling Up Arts on Prescription Model from Evidence to Regional Implementation. This is a webinar that is organized in the framework of a number of activities that the Culture and Health Platform project is running. It's a project co-funded, of course, by the European Union, and as the title of the project itself says, of course, it's really dedicated to fostering the connection between the art sector and of course the health sector. Today we're going to have a specific focus on looking at what's happening on arts and prescription in different countries, both at national level, with some very nice examples from the Baltic area of Europe, from Greece, and as well from Italy with a recorded video. And then we're going to look as well at a bit of experiences from regional level. We're very happy to have colleagues here from Central Denmark, from Flanders, and from the European Group of Territorial Cooperation, Gorizia and Nova Gorica. So it's Benedetti and the colleagues will join us in a second part of the meeting. But first of all, actually, to kick off, I'm very pleased to give the floor to the supranational level. We're really pleased to have Niels Fietje with us. Niels, you're going to guide the first part of the meeting, give a little bit of an introduction, and then run us through, help us with the presentation of the colleagues from indeed Greece, the Baltic Sea, and Italy. Niels, the floor is all yours.
Thank you very much, Michele. Thanks for inviting me. Thanks for organizing this meeting. Very pleased to have the opportunity to speak with colleagues at the regional level here from the WHO regional office for Europe. So my name is Niels Fietje. I'm a technical officer. I work on culture and health, and specifically within that space, I've been doing quite a bit of work on arts and health, and I'm very pleased here to be joined by a lot of colleagues that I know and that I've worked with. So I'm going to be moderating the first panel, the panel on arts and prescription models and regional policy frameworks. And as Michele was saying, I have a few minutes that I'm going to spend just talking a little bit about the context and maybe making the case for arts and health and culture and health. And I'm going to do that in three ways. I'm going to do it 4 ways today. I'm going to talk about the evidence base. I'm going to talk about the health economics. I'm going to talk about desirability, what people want, and I'm going to talk about what public health needs currently at this point in time. So I'll start out with the evidence base. And in fact, I'm not going to spend a huge amount of time on the evidence base, because I think the evidence base the evidence for arts and health has largely been made. Now, that's not to say that there's not a lot more that can be done, especially on the kind of smaller individual level, understanding better the active ingredients, understanding which activation works better in which context. There's a huge amount of evidence and research that we still need and that we'll continue to gather. But I think the point is that at the large scale, at the question of can cultural engagement impact and benefit health and health outcomes, I think that general narrative is getting more and more well established. And that's partly because of a report that that WHO put together in 2019, which looked at the impacts of arts on health promotion, illness prevention, on the treatment and management of disease, and found that even then in 2019, there was a lot of evidence already circulating. But 7 years on, really, from that report, we're now seeing a sharp increase in evidence, even at the meta level, with systematic review levels, meta umbrella reviews. All sorts of evidence is confirming that the arts and cultural engagement can have a health benefit. And in fact, we're going to be publishing a Lancet series later this year with a group from the Jameel Arts and Health Lab and a number of authors from across the world that is making the case that active and receptive participation in the arts can play an important role in promoting good health and health equity, in preventing illness and treating acute and chronic conditions across the lifespan. And later next year, we're also hoping to publish a new WHO report, which is hopefully going to be able to make the case very strongly that just engaging in culture, just cultural engagement on its own, without any specific health need in mind, so that just engaging in culture is a form of health behavior and can increase population health. So there's an increasing amount of evidence at the population level that is also beginning to become very strong. So that much for the evidence base. As I say, I think that's become stronger and stronger over the years. Where we've been lacking up until now, I think, is the case, the health economics case. So I think initially when arts and health was being discussed at the kind of policy level, ministerial level, the question was always put back to say, well, the evidence base is not strong enough. And I think that's that response has begun to diminish. Now the response is, well, what are the health economics? How much money are we going to save if we invest in arts and health and cultural engagement? And that continues to be a case that needs to be made. However, at the end of 2024, the UK government published a report on how to monetize the impact of culture and heritage on health and well-being. And it found that in relation to the UK economy, associated gains from current investment in cultural assets led to gains to the UK economy from improved health and well-being and productivity at the level of around £8 billion a year. And these kinds of reports are being followed based on the models that were being developed, or have been developed for this report. Similar modeling is showing that similar gains are existing in other parts of the UK and in other parts of Europe as well. So the health economics argument is also beginning to strengthen and come through. But perhaps for politicians, one of the most important arguments is this in fact something that people want? And here again, I think we're finding that not only is it something that people want, but it's also something that people inherently understand. And maybe this isn't so surprising if we ask ourselves, have we ever been touched by engagement in the arts or culture? Do we feel its own impact on ourselves? Have we ever listened to some music or been at an event or sung together in a choir? And what impact has that had on us? I think most of us can relate to the physiological impact that engaging in culture and the arts can have. And in fact, at the end of 2025, a Eurobarometer, which is kind of the leading survey tool within the EU region, a Eurobarometer survey asked people how they felt about the relationship between cultural engagement and health. And 87% of Europeans and 89% of young Europeans believe that cultural participation enhances their emotional and physical well-being. I mean, these are kind of levels of acceptance and level of understanding that you typically don't find in terms of consensus, particularly nowadays. So it's, I think, very important to recognize that at the public level, the idea that culture and health are related is already firmly entrenched. And maybe the last thing that I want to say before I open up to the panel is the fact that I think we're at a stage in public health where public health needs the support and the help of the cultural space. At WHO Europe, just a week ago, we launched a public event called Rebooting Health Promotion. It comes 40 years after the Ottawa Charter, which was a milestone. The Ottawa Charter was a milestone at the time for health promotion and for seeding the idea that health is not just a biomedical question, but that it is created in the social and cultural contexts in which we live, in which we play, and in which we die. And that concept has grown over the years, but is still finding resistance. We're still very much entrenched in the biomedical model. We still look towards pills and vaccines as the key innovations that provide health. But more and more, we're having to recognize that concepts like social connection are critical when it comes to our health at the individual and at the population level. And in fact, the WHO has an ongoing commission on social connection, which published a report on loneliness late last year, which said that loneliness affects nearly 1 in 6 people globally and causes about 871 deaths annually. And if we're willing to accept that loneliness is a public health issue, that social connection is a public health issue, then we have to also accept that there is no pill, there's no vaccine, there's no medical treatment that is going to prevent loneliness or that is going to enhance social connection. And it's exactly in this space where things like social prescribing, arts on prescription, arts on health and culture and health generally have an incredible role to play to improve the health and well-being of the population. And in fact, even beyond social connection, even beyond the kind of spaces where we are perhaps more willing to or more ready to accept the connection between arts and health, we're also making the case that in other spaces, like for instance in climate change, the importance of culture is critically important. And we just published a policy brief last week on the intersection of arts, health, and climate change, where we argue very strongly that the climate crisis is in fact a cultural crisis, and that it's a space that we won't change unless we change culture. So we're in a time, I think, where the need for the intersection between culture and health is becoming ever more clear, and it's something that more and more countries in the European region and beyond are beginning to act on. So I'm really pleased to be hosting this panel where we will learn about arts on prescription models that have been implemented across the region, across the European Union. And in fact, I'm very pleased to start us off with Nikos Stefanis, who masterminded a arts on prescription for mental health model, and which has since become a Greek national model, and has been incredibly successful in integrating that model at a national level. So Nikos, the floor is yours. I'm very, very keen to hear from you about how you've been able to do this. Over to you.
Thanks, Neil. Hope everybody can hear me. Thank you very much for the organizers for the invitation. It's a true privilege to be here and talk to you about the Arts on Prescription program. I hope you can see the slides. Is it okay?
Yeah.
Okay,
Yes.
great. So I'm the chairman of psychiatry in Athens University, and I'm going to be describing the Arts on Prescription program. It is definitely the most complicated and challenging project I've ever undertook from our department. This is some pics from our recent conclusion of the Arts on Prescription program, the 4-year Arts on Prescription program in Greece. Down on the right, you can actually see Minister of Culture of Greece. She's an archaeologist, and the Minister of Health, who just a few months ago made Arts on Prescription law of the land. So since the 10th of March in 2026, Arts on Prescription is here. It's official in our country. Every psychiatrist can now prescribe 3 or 6 month exposure to arts to his patients, which is cumulative achievement and a direct, I must say this, a direct result of the 4-year national prescription program that we undertook. Our inspirations have been the same, as Niels mentioned, and of course, driven from our limitations. Anybody working in the national health system, in the mental health national system, has experienced these limitations, and we are looking ways by which we can enhance the well-being of our patients. So I'll be talking about arts on prescription, but especially focused on people with mental disorders. So what is the Greek model, so to speak? How did we go about it? So the Ministry of Culture commissioned the University Mental Health Research Institute to create a big research group that would be in direct contact with big cultural organizations in Greece. And in these cultural organizations, which were the hub where the actual arts and prescription took place, there were embedded senior and junior mental health professionals, and also senior and junior artists. And they co-created within the cultural centers, they co-created a 3-month program. And this program could be either music, it could be either in theater, it could be in photography, it could be in many different types of art. And it was a challenge because nothing like this existed before in our country. There were individual small groups working on arts of prescription, but this was definitely at a much more larger level. So it was actually indeed an invention of a process. And this process had many components in it. What would be for example, the safety rules of all these patients coming from the mental health units to the cultural centers? What are the rules of engagement, so to speak? What was who would be the right people to be embedded, the right mental health professionals and the artists? What would be their degrees in order to be able to sit with the patients and perform and be there for 3 months with them and support them? How do you organize a digital platform? How do you secure anonymity of all the people involved? Because there was also a very big research program that I'm going to be talking about. So there were so many new things that we had to discover, so to speak, in the process. So we had 21 major cultural institutions engaged from out of the country. Just to give you a scope of the project, it took about 4 years. We had 1 in 5 community mental health services within our NHS that contributed with patients, 21 cultural institutions, 118 new jobs created for mental health professionals and artists, 1,026 beneficiaries from mental health services joined and signed an informed consent to participate in this initial research study. So each patient was each beneficiary was participating in a 3-month duration of guided art exposure with regrouping and self-reflection at the end of each session. So there were 12 sessions, 12 exposure sessions. That resulted in 2 large randomized controlled trials. The randomized controlled trials are the golden standard by which we do our business, and the stakes have been slowly getting higher. So we need to provide better and better type of evidence for whatever exposure we are looking for. This is the kind of design that the study had. So in the red, you can actually see the exposed participants, and in the green, you can see the waiting list. These are treatment as usual patients. So what we are going to talk about are the results at the end of the 3-month exposure, comparing after randomization the control group or the treatment as usual group with the one that was exposed to different art centers. What were the outcomes? They were typical outcomes that are used in these kind of circumstances, very well recognized questionnaires like the PHQ-9, the GAD-7, and the Warwick Edinburgh Mental Health Wellbeing Scale. Just to take you through the results, I mean, we have a preprint published, and I'll be giving you the link for that if anybody is interested in looking how the methodology and the results are combined. Suffice to say, 126 participants, 925 of them were actually engaged and randomized. What were the diagnoses of these people? So interestingly, the majority of them had a diagnosis of a serious mental illness. So we're talking about schizophrenia, about major psychotic disorders as the first major category, about 37% of the population. The second big group were affective disorders and anxiety disorders. a third group, bipolar disorders and substance abuse disorders and so on. So you can see there was actually quite a large spread of different diagnoses of the people who got engaged in these art and prescription programs. Just to take you through, just to mention that we were actually targeting people that were in their mid-50s. That was the mean age of the population. They were actually quite socially deprived and not very highly educated, as one could imagine. And about half of them lived alone or outside a family. So the statistical methods, I'll really not get into, a very complicated but very nice way of analyzing results. I'll just show you this diagram. On the left is the pilot A that took place in 223, 224, and the one on the right is the second pilot that just has been concluded. And as you can generally see, you don't have to know everything about this type of research and linear mixed models effects. But look at the line that is in blue. That is actually the decrease. You can notice the decrease in depression in both pilots. You can notice the decrease in anxiety, and these are significant, as well as an increasing well-being, compared with the red line, which represents the treatment as usual group. So in percentage of reliable improvements, it was not a huge reliable improvement, I must say that, but about 10% actually improvement was noticed in all outcomes compared with treatment as usual population. So the mean improvement on the PHQ, the depression scale, the GAD, were around the range of minimally clinically improved difference. So it is clinically relevant. It's a randomized design, which is a major asset. It's a large RCT, one of the largest, I understand, done in Europe. Importantly, the patients had serious mental illnesses, and we are able to reach a population who are socioeconomically deprived, and at the same time, individuals who face more barriers than average citizen in accessing arts and prescription activities. And you have limitations that have to do with the design of our RCTs that we have taken into consideration. We had marvelous feedback and from almost everybody. There were no major incidents happened in these 4 years that the program took place. The feedback was fantastic, much more than I expected, to be honest. But at the same time, satisfaction was very high. There were limitations, and it was interesting to notice these limitations, and they are going to be hopefully forming policy later on as the program continues, and will be. We have an assurance that it will be continued and sufficiently funded. And they have to do about the duration. Interestingly, the duration, the 3-month duration, was considered the major limitation of the study. All other satisfaction measures were high. And of course, some systemic lags and systemic problems that are embedded mostly in this type of research. Our conclusion, I think, is quite stable about the efficacy of the arts and prescription program, and that they have a beneficial effect on the mental health of patients with a mental health illness. It will work. We're in this phase where we are making this transformative in the sense that we're incorporating this into the national health system, and hopefully in a few months, every psychiatrist will be able to prescribe arts and prescription to his patients, his private patients, or in social settings, by doing exactly the same process as he would describe any type of medication. And we are organizing that with the ministry at the time being. I'm going to leave you with some relevant links that you might be interested in. This is a marvelous documentary, about 30 minutes, describing the arts and prescription program, and a reprint of the Pilot A manuscript that you can, it's publicly available for the time being. The results of the major study are under review as we speak. I'd like to finish by thanking a huge group, but mostly people from the Ministry of Culture of Greece, and my research group that has been so much dedicated and supportive throughout the 4 years that the program took place. So thank you very much for your attention.
Thank you so much, Nikos. I've heard this presentation a couple times. I feel like I get more impressed every time I hear it. It's fantastic that this has been included into a national law. And it's great to see that some people are beginning to raise hands. By all means, please do think of questions to ask. We will have a little bit of time at the end. So either pop them in the chat or ideally do ask them during the Q&A. But for now, I want to move on the discussion to another wonderful Arts on Prescription project, which is the prescription of arts and in the Baltic Sea region. So arts on prescription for mental health at the Baltic Sea region. This is a project that included a number of countries around the Baltic Sea. But today we're going to hear from first Inga, who will talk about the Latvian experience of arts on prescription, and then from Stine, who was the program leader for arts on prescription based in Denmark. So I'm going to hand over to Inga first. Inga, the floor is yours.
And Niels, we have switched a bit around just to tease you a little bit and to make it more dynamic.
Okay.
So
let's make it dynamic. and I have to say it makes sense because obviously, Stina, you had more of the kind of umbrella perspective, and Inga the implementation on the ground in Latvia. So please, over to you, Stina.
Thank you. And hello, everyone, and I'm very pleased to having the opportunity to present the Arts and Prescription model, as we call it, AOP in the Baltic Sea model, under the project Arts and Prescription in the Baltic Sea region, which took place from 23 to 25. And I will do that with my great project collaborator, Inga. I will start off by presenting the model, and Inga will, as you mentioned, Niels, talk a bit more about how we are trying to implement it, both in Latvia, but actually in the Baltic Sea region in total. So the project was developed by 13 partners in 7 countries in the Baltic Sea region and included municipalities, regions, education and training schools, higher education and research institutes, an NGO, and an international governmental organization. And next slide, please. Yes, the reason why we did it was because even at that time, there was quite a lot of evidence that emerging evidence that arts and prescription was this promising model that could improve the mental well-being of people, especially also those who are suffering from loneliness. But we had only tried it in small-scale pilots in the Baltic Sea region. And one of the reasons that it might not have been succeeded in a larger scale implementation was that there was a lack of long-term financial mechanisms, but also a lack of awareness of AOP and how to actually set up AOP programs at a municipal and regional level. So next slide. What we wanted to do was to improve the way that it could be upscaled by creating a generic AOP concept that could be adapted to different municipal and regional needs, and a practical arts and prescription guide that could support public authorities in setting up AOP programs. So it would have themes such as how do we finance it, how do we evaluate it, how do you create cross-sectorial collaboration, and so on and so forth. We also had twinning city opportunities for cities, regions, municipalities outside of the partnership that could be involved in following our pilot phases to learn from our failures, mistakes, and successes. Then we also have developed an evaluation framework to provide research-based findings from 24 pilot programs, including implementation strategies that can support different areas in setting up their specific AOP program. And we also have a fundamental section in our AOP guide that we will have a QR link to in the end of this program. And we encourage you to look into this guide because it really is a good tool to help you start up AOP programs. Our model was developed through 24 AOP pilot programs in 8 sites in Denmark, Poland, Germany, Latvia, and Sweden between 23 and 24. And the program was targeted towards people with or at risk at developing mental health issues. And we tested it on many different sub-target audiences, such as only young people groups, only men's groups, mixed age groups, new country residents, working women, elderly people, disabled, and many more. And again, if you visit our project site, we also have a link to that in the end, you can go in and see how we piloted differently in the different regions. But basically, the different target audiences would be entered into groups. As you said, Nils, in the beginning, pills don't create necessarily fellowships, and an AOP program can do that by bringing people into a group of 8 to 14 people who are meeting 8 to 12 weeks weekly, either 1 to 3 times a week, 2 to 3 hours each time. And in our model, they would be introduced to different arts categories, 3 to 5 usually, including music, visual arts, dancing, theater, and so on and so forth. Next slide. And each piloting partner would find out how what specific target audiences they would include. But this was the pathway for the participants in all the pilot phases. So an individual would meet a referral channel. In Odense, for instance, we targeted our AOP program towards young people. So the referral channel could be a student counselor, an NGO working with young people, a psychiatrist team with focus on young people. If they found that this individual would benefit from AOP, they would send them to a link worker who would have a more in-depth conversation with the individual. And if the individual and the link worker then would find that, yes, AOP did indeed fit this participant's needs, the link worker will then go to the activities with the individual, as well as the other individuals referred to this program, where they would be a supportive figure all the way through. And the facilitators would then be in charge of doing the actual facilitation of the different activities. And then our aim was that they, by the end of this time, would have long-lasting social connections and a better outview of life. So this is the model, and now Inga will explain how we are continuing working with the model and trying to implement it in a more sustainable and widespread scale.
Hello, I'm happy to take over. As Niels already said, I was responsible for one of the Latvian pilots. I will mention how we are moving on in Cēsis municipality, but each of the partners after the piloting phase had to create an action plan. And actually, thanks to this webinar, we reached out to each of the partners with Stine and asked them to update and tell us how they're actually doing with their imagined action plans. And actually most of the things planned for this year are already taking place. So in the alphabetical order, Bremen, they have founded a Bremen-based Center of Expertise for Arts and Health. And this center has started developing projects and fundraising for AOP. As this pilot was based in the Adult Education Center, they're also continuing this path by transferring AOP within the center and also taking the role of advocacy and fostering policy-making processes both at regional and national levels. And as we move on, you will see that some of the tendencies are similar to different partners. So Cēsis municipality also founded an association, Culture and Health Latvia, that serves as a non-official, but still a focal point for culture and health collaboration in our country. We also do fundraising, and one of the project proposals has been very successful, and the Museums and Prescription program in the municipality will be EU funded and implemented from 26 to 29. And we're doing also research and advocacy for culture and health at national level. We have founded the Interministerial Working Group Culture and Health, and the association is also coordinating its work. In Odense, Stine can tell more about it. You have created a sustainable AOP program via funding from the Ministry of Culture and Cultural Region Funen, as well as AOP has become a part of the Cultural Room for Youth program. So we can see that partners are looking for different accessible funding sources to fund the AOP, while it is not funded by national sources. Also, the Odense municipality has become partner in the National Alliance for Culture and Health and is advocating very actively for the inclusion of AOP in the social prescribing in Denmark. And internationally, municipalities partner in the Baltic Sea region mental health platform. We are very happy and proud for the region Norrbotten, who have reached a political decision in the Regional Development Committee to finance and to extend AOP to all the municipalities in the Norrbotten region, starting from 26 and ending in 2028. And they're also taken the role of boosting knowledge and advocating for policies and expanding knowledge exchange and best practices. So you can see really how we are actually operating in a very similar way across the partnership. Saldus, another Latvian municipality that was involved in piloting, carried out a qualitative study on mental health challenges and opportunities for cooperation between the sectors in the municipality. And based on that, they are implementing a program for municipality employees, and also have been successful in a project that will be funded by EU that will allow a new program of social inclusion based on the AOP experience in 26-29. And our partners in Poland are also part of a project, Arts for Health and Wellbeing Network, ArtWellNet, along with other project partners. They're also been able to establish a joint position of the Convention of the Marshals of Voivodeships of the Republic of Poland regarding culture and health. And they also are looking at other funding possibilities, such as Back to Woods project, to find resources to continue funding AOP programs, and also internally seeking for a possibility to create a micro grant fund for the AOP programs. And not only in the Baltic Sea region, but also beyond, there have been other countries and other partners who have been interested in the AOP Baltic model and in trying it. And Stina will be able to tell more about that.
Yes, I can just say I was in Greece a couple of weeks ago, and it was such a privilege to meet a lot of people from around the world. And it was exciting for me to hear that, for instance, in Malta, they're planning a national arts and prescription program, and they have found our model a big inspiration, as well as our guide to help them to start up cross-sectorial collaboration. Portugal is also now launching an AOP program and are very inspired by our model. And we in Odense are contributing as a mentor to give them some examples of how they can do it in a practical way. Also, Belgium is setting up AOP programs now, and are very inspired by how they have done it in CESIS, where they have done it especially in the museums. So they call their local AOP program Museums on Prescription. And also in Italy, in Foglia, I am poor in Italian, but they are also promoting the Baltic approach at the moment to mobilize interest and political commitment for a regional AOP program. Yes, and I think this was our last slide, so we encourage you to visit our website as well as our guide.
Thank you so much, Stina. Inga, I would encourage you to put those links also in the chat. I think one of the really fantastic things about the Arts on Prescription of the Baltic Sea project has been the toolkits, the kind of guidance, the website, all the kind of things, the practical things that help implement Arts on Prescription that you've produced. So not only are they beautiful to look at, they're also very helpful. So do put them in the chat so people can access them. Great. We have one final contribution from Annalisa Cicercia. Annalisa couldn't be with us today, so she sent a video contribution. I will introduce her because I'm not sure if she does it herself in the video. Annalisa is the Vice President of the Cultural Welfare Center in Italy. She's been a champion of arts and health, of culture and health for many years, and one of the driving forces of Arts on Prescription in Italy. So let's see if we can cue up the video and listen to what she has to say.
Yeah, thanks, Niels. We'll kick off the video. Please let me know if you're going to hear it. It's always like a bit of a roulette if these things work, but it should.
Thank you all, and thank you in particular for inviting me. I'm so sorry I couldn't make it and be, if not physically, because we are, I think, all digitally connected, at least live with you. So thank you also for accepting my small recorded contribution. And I will share with you presentation. It is about the survey that we have recently carried out in Italy about arts on prescription. So as you see, this is our first national survey, and I've tried to summarize some evidence and, so to say, lessons for scaling up the projects. So before this surveys, we had no national picture about the arts and culture of prescription, or more in general on social prescription in our country. But we know and we knew that in Italy, thousands of people currently receive arts activities prescribed by doctors, pediatricians, psychologists, or social assistants, and so far no one had counted them. Briefly, and thanks to the Fondazione Compagnia di San Paolo, who has supported and funded this research, our Cultural Welfare Center has singled out 918 organizations active across Italy, and their sectors range from the performing arts, museums, libraries, health, social services. So it is not a picture only concerning the cultural or artistic sector. It is something that crosses many areas and sectors. They all resort to the arts and culture for health and well-being purposes. And they are all present in all Italian regions, but they are not evenly distributed, as the north and the center of the country concentrate most of the organizations. More in detail, we found two models within one same and shared field. We have 617 units that we have called social prescription units that have active social prescription pathways, always and only concerning the arts and culture. They have a stronger healthcare identity as organizations. They have comparatively more doctors or psychologists in-house within the organizations. They tend to be older and more established, and they tend to be concentrated in the center north of the countries. But we also found 301 what we have called cultural welfare units that represent 1/3 of the sample. And among them, 19%, 97% are willing, if made able to, allowed to prescribe their activities. And their organizations are slightly different. They tend to be more characterized by arts and culture for health without a formal referral. They tend to be rooted in museums, libraries, and nature organizations. They tend to have a larger scale and more community reach. An higher cost borne by participants, let's say beneficiaries, and they tend to have strong local roots and less public funding. In general, and focusing now on those who prescribe arts and culture for health and well-being, who prescribes? The most relevant form of prescriptor is a psychologist. Then social workers and teachers reach about 1/4 of the universe. Then we have 20% are prescribed by pediatrician, 15% by psychiatrists, and 12% it's self-referral, and only 8% by the general doctors, or we call in Italy the doctor of general medicine. This major absentee is not due, in our view and according our data, to a lack of interest, but because the infrastructure for referrals does not yet exist, and in general we have an enormous burden on the shoulder of these health operators. And about the link worker, which is a strategic figure, but not so common and not so frequently found in the organizations that we have interviewed. In the social prescription units, 24% they usually resort to a link worker. 54% have no link worker contact, but 49% have link workers with structured training. Structured, that is, so to say, because there is not a formal training orientation, protocol, procedure in Italy for the link workers. What are the activities which are prescribed in the field of culture and the arts? Well, the first place is for reading aloud, then museum and heritage education, cultural and narrative walks, theater and drama, visual arts, music programs, and art skill training. Some very relevant aspect in our view is that we found a documented impact, or a very strong and searched impact on mental well-being and relational objectives. Another important figure is that 96% of participants complete the programs that are proposed to them, and 45% of the initiatives can document lasting benefits. Generally, the settings are represented by cultural places, so to say, museums, library, parks, or third sector premises, and clinical settings, of course, I could add, are a minority by design. And the venue is not neutral because it is part of the intervention, which tends to be non-clinical. What are the structural gaps that prevent scaling, at least in Italy, and starting from our experience? One is the missing link worker, which in turn reveals that much of the process is still informal and is not recognized, is not structurally based. The second element is the absent GP, and while pediatricians, for instance, are more ready to be involved, there is still a problem of integrating in the basic health services this sort of new resources. And then another problem is about funding, because more or less 30% of the organizations operate without structured funding. So these are problems and points possibly to be addressed in the future. From evidence to scale, we think there are 3 policy levers that could be considered, and we suggest, as at least for our country, should be borne in mind. One is, again, build the referral infrastructure. So it is necessary to build and strengthen and test and experiment and perfect the referral infrastructure, and that is the structural dialogue from for the different components, those who could prescribe, the cultural and artistic offer existing at the level of the local community, and the link worker. Second, create enabling regulatory frameworks. It is being started. The discussion is still making the initial steps in the National Working Group on Social Prescribing, which has been created by the Istituto Superiore di Sanità. There are different institutional, administrative, financial questions to be addressed, so we still need to develop a further stage there. And then it is very important to fund systematically and for equity, also to fill the geographic and social gaps that ideally social prescribing is able to address and to close and to fill. So I thank you very much for your attention, for the opportunity, and I wish you all an excellent work. Thank you.
Fantastic. Thank you so much, Annalisa Cicetta. We have run out of time for this panel, but Michele, maybe I can just grab a couple of minutes.
Absolutely.
First of all,
yeah.
First of all, to say there's a Q&A section, and I encourage all of our panel members to have a look at that Q&A section and maybe pick 1 or 2 of the questions and answer them if you can. So that's an icon next to the chat section. So there's 2 different sections there. And if you have any questions that we won't be answering in the Q&A now, then please do put them in the Q&A of MS Teams. But I do want to ask one question to all of our panel members, because I think it's come up a couple of times in various ways, and that's a question around funding. I think what was very interesting in Annalisa's presentation is that it's clear a lot of this is kind of unfunded. It's work that is happening, but not necessarily very well supported financially. Also, in the Italian case, it's interesting to have the Ministry of Health involved a little bit more strongly. I think in the instance of Greece, the Ministry of Culture is very much driving this work. But correct me if I'm wrong, Nikos. And in the Baltic Sea project, a lot of this was EU funding, so it was actually supported by a kind of a third party. But perhaps each of us can say just a little bit about not just the funding in the past, but also the funding going forward. What are your thoughts, Nikos, Stina, and Inga, about funding arts on prescription in an ideal scenario? Maybe I go over to you, Nikos, first.
Okay. This whole project was funded by the RRF, the Resilience European Fund. And that is ending in a couple of months. So the question of the continuation of funding is very much a Ministry of Culture issue at present. So there is understanding that it will continue in the same cultural centers, with the support of the financial support of the Ministry of Culture. So that is publicly said. We have no reason to dispute that. But it's also about expansion. And, we deal mostly with people who are mentally ill, who have a diagnosis. We'd like to expand this to other medical professions. Our friends in neurology, in oncology, have asked us so many times that they can participate and get engaged. So we'll be actively looking for funding from other aspects, from the medical community, so to speak. But I have no question in my mind that the program will continue for several years at least, with the existing funding that the Ministry of Culture has actually committed to.
That's excellent news. And in your case, the kind of driving force here is the Ministry of Culture. Stina and Inge, in maybe focusing and just answering it briefly, focusing in your cases on your respective countries. Do you have a sense of where funding might come from, or ideally where it might come from? So maybe Inge, to you first.
Yes, thank you. I can speak about Latvia, and responding to a question in chat. It was in Latvia that the interministerial working group has been established. I think there won't be something like only national funding. We have to look into diverse resources and how we can pull them together. What I can tell about Cesis municipality, we saw that during the pilot phase, when we had to establish all the system and to train the specialists, it was quite expensive. But at the moment, the museums are reviewing their own working plans, and they're already adding museums and prescription program as part of their regular work. So it is not anymore seen as something extra. So that would be part of the museum's own funding. Also, the referral channels, as we call them, are seeing in-kind possibilities of supporting the programs, such as, for example, the social department, which are our strongest referrers. They are looking into possibilities of providing transport and so on. And then municipality has also found a part that they can fund. And then we are also fundraising and looking for EU funding. So in that way, we are pooling the resources and also restructuring, revisioning how we use the resources that we already have, and fundraising for what is still lacking. This will be most probably the scenario in Latvia.
So a mixed model.
Yeah.
Stina, do you have anything to add? What's it like in Denmark?
Yeah, I just want to say that I think it's very important to start up setting cross-sectorial collaborations from the beginning, because there might be a specific resource that will start financing it. In many cases, it's been the cultural sector in Denmark. But once you set up these cross-sectorial collaborations, you also include the other sectors, and during this collaboration, they might find that, yes, indeed, this can also suit our needs. It might take a little extra time, but once they see some of the first pilot results, they can see, okay, this works. I can also contribute with that. And that's also what we see now in Denmark, that maybe it's been the cultural sector who has taken the lead, but more and more organizations that has to do with the social and healthcare sector, they are also now contributing both with resources but also with financing.
Great. Thank you so much for your insights. Thank you also for your contributions, Nikos, Inga, Stina, and of course, Annalisa. I think this was a super interesting session. It's very practical. And I think it's exactly the kind of thing people need if they are interested in developing arts and health in their regions. So thanks again. I was going to do a 1-minute stretch. I was going to encourage everybody to do a 1-minute stretch together, but I think we're running a little bit behind. So I'm going to encourage you to do it on your own separately. Feel free to turn the camera on or off. But I'm going to hand back to Michele, and thank you all for listening, and look forward to the next panel. Michele, over to you.
Thanks a lot, Niels. And indeed, I think everybody's stretching a lot their fingers, as we've seen a lot of questions coming in the chat, in the Q&A. So indeed, please Do keep those coming as well. And indeed, as we discussed, Niels and all the other colleagues, feel free to, of course, to stay with us, first of all, but also to keep responding to the questions that you see in the chat. And I would suggest something that we haven't discussed in the preparation, but if there's something that remains unanswered, maybe it's something that we can do in the follow-up as well, with a little bit of frequently asked questions here. But I think we're going to have still a little bit of time as well later. We have indeed like a second part of the discussion, and in this case, we're looking again at experiences. In this case, from the regional level, and I'm very pleased to have three colleagues here with us from other countries and from members of Euriga as well. We have Kato van Popeng, Policy Officer in Culture, Health and Wellbeing at the Flanders region. We have Mikkel Ottov, Health and Cultural Consultant of Central Denmark region, and Ezio Benedetti, your project coordinator from the European Group for Territorial Cooperation, GeoGRIT. So I will highlight them for you here in the screen. But in the meantime, I would like to ask. Indeed, we're going to go with very quick round of experiences here, and we'll start with Kato, if that's fine. From the Flanders point of view, it would be great to know how health and culture, how cultural policy is organized, and how it affects as well the connection with the culture and health and well-being sector, which are the key policy areas, and what are the key upcoming actions that you see here happening in Flanders. Kato, on you.
Yes, thank you for inviting me. This has been so interesting so far. I've been noting a lot. So I just wanted to thank you first for this. So the current policy situation in Flanders, in region of Belgium, is that we have a lot of the mentioned activities between arts and health are already existing in Belgium, but the problem is that it's really fragmented and it's really scattered. We have initiatives within the arts working on health and care. We have them with heritage, with museums. We have different kinds of arts and prescriptions programs, but we have a lot of programs that are community-based arts, connecting people, connecting communities. But these remain grassroots initiatives that are temporary, they're project-based, they're not structurally embedded. So now we are looking at a way to, first of all, unite all of these projects between arts and health. But more importantly and very interesting is that this year we have the opportunity to work on a policy framework together with the Department of Care. So the Department of Culture, Youth and Media is working together with the Department of Care Flanders on a shared vision, because we know that there's a need for this shared language, but also more, as Annalisa said, was really interesting. She said that whereas these regulatory frameworks, the field grows, and I think that by working together as policy, as ministries, we also want to make this field grow. So only in Belgium, the government is really a bit complex. It's also multi-level. We have a federal government that is responsible for financing the curative healthcare, and culture itself is more a regional competence. But we have in the federated entities like Flanders, they're responsible for preventive healthcare, organization of health and care in general, and also social care and well-being are mainly regional competence. So after what I heard today from the many examples from arts and prescription in other regions, it gives me a lot of hope that we can support a program more on a regional level.
Thanks a lot, Kato, and maybe I'll come back to you later as well if you have some concrete examples of wellness or specific initiative that you want to highlight. But as well, I say that you're also making a lot of connection with everything else that the other speakers have shared, and as well, I think that some of the questions that people mention to the first part of the panel might something that you might also want to touch on. So, of course, happy to hear indeed that even with the complexity of Belgium, living in Belgium, I can only testify that it's even more precious when there is like a very strong collaboration across sectors. This is really great, and we're staying of course at regional level, and we're very happy to have Mikkel with us from Central Denmark. We actually met in Brussels some weeks ago, indeed, and you also met with Kato, understand, with colleagues from Culture Action Europe. So a lot of movement as well in the connection between the arts and health sector. Can you tell us a little bit about Central Denmark's region work and how as well it's important to have this international connection?
Absolutely. Is the connection all right?
It is.
Okay, good. Nice to meet you, and what inspiring presentations from you guys. The Greek example is mind-blowing, and also the work being done in Italy. In Central Denmark region, there are 4 regions in Denmark. We are one of them, with the biggest city is Aarhus. We have 19 municipalities in our region, and the regional's primary purpose is to work with hospitals, psychiatry, but we also have a cultural development division, and I'm part of that. 10 years ago, I was hired as a cultural developer, and very soon that became my focus became arts and health, which was a totally new thing at that point. But now, after these 10 years, we are now 4 specialists in arts and health working as consultants throughout the region for both municipalities, hospital workers, politicians, all sorts of people. And I think that's sort of the point, is that we have seen a huge need for these people who can build bridges between the cultural field, the health field, social workers, psychologists, all sorts of people who can translate languages between the different genres and professionals. We are not specialists in arts and health, or in culture and prescription. We are more general specialists in the arts and health field in general. So dancing with Parkinson's, reading groups, writing groups, dancing, arts, workshops in psychiatry, music in hospitals, all sorts of things. So I think our general perspective is to sort of raise the awareness of the health literacy around culture. So knowing that cultural behavior is health behavior, and there's so many different angles to that. That's such a complexity to that, and that requires politicians and local management in health fields and in the cultural sector to sort of change the way we have done things in the past. So we are trying to, we do a lot of communication. We have recently made a new policy on health and culture that we try to, this is our regional policy on health and culture, and we try to give that to municipalities and to national levels and to European partners, and say, could we perhaps make a shared vision for policies on health and culture in EU, in different nations, and of course on regional and municipal levels. We also try to find state-of-the-art solutions in the world on a European level that we can adapt, that we can tell people in our region that here some people are doing this in England, in Australia, throughout the world, and say some people have made state-of-the-art research, state-of-the-art ways of implementing on scaling concepts. You should do this in our local museums, in our music schools, in our universities. Some people have done this. It's easy to adapt, and we will help you translate or model this into local circumstances. So with the help of Niels Fichte from the WHO and European partners, we have been able to I think make quite an impact because of these big logos. So coming together, for instance, on a European level, we can use the WHO logo, we can use the EU logo, and help local authorities change the direction, have a bigger impact, create better funding ways so that arts and health can succeed in Denmark and in EU.
Thanks a lot, Mikkel. Indeed, you raised basically why we're also here today. In a way, we are as a network of regional and local health authorities. We started the collaboration with the colleagues from Culture Action Europe and many others in the room exactly for that reason, to make the transfer, let's say, to what's happening at international European level to the impact at local. And I see also so many comments in the chat that I'm really pleased to see about experiences from nurses, from healthcare professionals, and how this is really working in concrete. And third part, Ezio, we're also very happy to have you with us, because of course you bring still, let's say, a regional local perspective, but also with a new different twist, as you also work strongly cross-border. You come from a region as well that has a big history and tradition in the mental health part, which is also something I see raised some interest in the Q&A. So Ezio, the floor is yours. Happy to have you with us.
Thank you, Michele. First and foremost, thank you for inviting us. Thank you for having us here. It's really a pleasure entering into this network for us, and we really think that it's an opportunity not only to network but also to learn. I'm very sincere when I say that this morning it has been extremely inspirational and useful for me. I mean, we are a cross-border entity. We are a public entity. We are an AGTC. And so maybe you could wonder, why are you dealing with health? What an AGTC can do on health? Health is one of our strategic assets. Health cooperation, cross-border health cooperation, has since its origins somehow shaped the evolution of our AGTC. We are on a historical border, maybe you know, between Italy and Slovenia, which was part of this Cold War division of Europe during more than 50 years. And so somehow we became a laboratory. And also when it comes to health, the AGTC, since its origins, invested a lot on health, cross-border health cooperation. Just two examples. We were awarded with an ITI, which is a direct award by the European Commission, for a €5 million project, which was realized within the Parco Basaglia. Parco Basaglia is the first place where Franco Basaglia, the well-known psychiatrist, started his activities in 1970. And he started exactly in Gorizia. So also by a symbolic point of view, this was a great challenge for us. It was more an infrastructural intervention to somehow also with a bottom-up approach, participatory approach, somehow to reuse this area, which is exactly on the border with Slovenia, between Italy. It's in Italy, but on the border with Slovenia, and somehow make it available for the use of citizens associations and so on. And so also the artistic perspective became immediately relevant for us since 2011. Then we had a second great event, which was the European Capital of Culture last year. Maybe some of you were aware, or some of you visited our region, our area, cross-border area. And this was the first cross-border ever European Capital of Culture. The European Commission awarded, it was the turn of Slovenia, Nova Gorica, and the local the two municipalities, the three municipalities actually, that are part of our AGTC had this brilliant idea, why not to extend the candidature cross-borderly. And so for the first time, we had two cities dealing with the European Capital of Culture. And also health, and mental health in particular, was one of our focuses. Obviously, speaking about culture, we all started since the very beginning looking to a connection between creative and cultural industries. The involvement of young generations and the possibility to create also socioeconomic development starting from culture. And this entered in direct connection with mental health and with the legacy of Basaglia. I'm sharing here a link, which is taken from our official platform of the Go Borderless. Go Borderless was the motto of our Capital of Culture. Obviously, it was invented, somehow launched in a different geopolitical circumstance than now, but still we believe it's relevant, and the European Commission still consider it as at least as a model to be followed, if not the reality that we are living every day. But okay, this is my own consideration. So the connection between health, art, and culture are at the very heart of our attention, and we are still developing activities within the Parco Basaglia. So it's an opportunity for all of us, I would say, for the whole network. Maybe we can discuss it in another occasion. My director will participate to the General Assembly in Bilbao and so on and so forth. But we really believe that this can represent also, by a symbolic point of view, a very, very important spot in Europe for what we are doing and for what we are discussing here today. And finally, we are now implementing a connection between a much smaller Interreg Italy-Slovenia project called Sanitas, which is aiming at adopting a cross-border protocol, facilitating cooperation between health systems and emergency operators in the case of specific situations like floods, wildfires, or even pandemic situations. And within this protocol, we are also willing somehow to involve the cultural sector. And we are discussing this now with the regional authorities and with the national authorities in Slovenia. You know, these are two different health systems completely. The Italian system is regionalized, the Slovenian system is very much centralized. So it's not always easy to put together the two administrative dimensions. But beside this, we are looking forward also for suggestions, ideas, good practices, as I said, so I will keep you updated. And finally, as Kato highlighted, we have the same problem of fragmentation here. It's a very fragmented reality where we have really excellent, good, small associations working. We are involved them as stakeholders in our projects. But the net, the real connection, also by an institutional point of view, is missing. So we would like to work also on this. Thank you. This is by my side. Obviously, I'm open to your questions or curiosities, and hope to see you soon also in visiting our territory. Thank you.
Thanks a lot, Ezio. It's really nice that we had, not only 3 different examples from across Europe, but also 3 different examples working with even different system between them, and in your case, it's 2 systems at once, which is even, I think, more complicated. I would like to go back eventually, as we're running a little bit out of time, but I think it's really valuable to have a bit of a follow-up question before the closing. I would like to check indeed if the 3 colleagues, you covered a little bit everything that we discussed, Mikkel as well, Bakato as well. I don't know if you also had some additional concrete examples that you would like to share with the audience, or some reflections as well to what you've heard so far from today. So maybe Kato, to you, if you want to add something.
Yes, it's of course a lot of the examples I heard. Many of you are working years and years in the field and have so much to tell. We have started this year with mapping all the initiatives we have in this fragmented field. So we have a very, we're looking very carefully to all the examples we have on arts and prescriptions, cultural prescription, and in relation to social prescription. We have, for example, an initiative in, we have 2 initiatives in Ghent, we have one in Kortrijk, and we have in Leuven and in Brussels. And now, actually this afternoon, there will be a network. They are organizing themselves to become more connected and really reaching out to policy, to us, to find ways to be supported. And we are also looking into this possibilities to support them in a better way. This is why we also have commissioned this research with mapping, but also the research involves scenario analysis on the needed funding, because also there's a lot of public funding, but it's also really fragmented. So we're also researching this, and also what is the necessary funding, or maybe it's a platform. So and eventually we are now this month we will be bringing all the experts, organizations, policymakers. We will bring them together to work through dialogue tables to work on this shared vision. In July we have a reflection day. The invitations are not sent, but we have over 130 experts on the list, on our invitation list. And so we hope, together with the research we have commissions, that with the end of this year, we could land with a cooperation agreement between the 2 ministries that would support the already existing initiatives we have in Flanders.
Thanks a lot, Kata. So many things to look forward to. Mikkel and Etiel, I'll come to you for some brief additions.
I think communication is key. Meetings like this has a huge impact on the movement throughout the world. And also I think that when making communication for projects, making very nice communication, I think, is very important. So using the language of the arts, really thinking about creating nice materials, web pages, magazines, whatever. I think that has a very big impact in this field, because it is something different than illness and sadness and sorrow. So using the colors, using the images, and using designers and people who know about colors to help us, I think that is crucial.
Communication. Thanks a lot, Mikkel. Very important indeed. And Etienne, coming to you for a brief addition.
Yeah, I forgot one thing which might be of interest for the participants today. As maybe you know, the Biennale is opening in this day in Venice. Biennale of Arts. There are 2 panels which are foreseen. I was trying to find them on the internet, but I couldn't. Related to the connections existing between arts, health, mental health especially, and also mental health, which is a very specific field in prison. Prisons, as you know, are places where social exclusion is even more visible than in other places. And Venice has this incredible prison, which is, maybe some of you know, if you know Venice, on the island of Giudecca, which is a female prison. It's a building from the 16th century, which has been renovated, but you can imagine the conditions also by an architectural point of view. But they are super advanced at a European level, I would say, in promoting projects, very, very focused projects on mental health in prison with a focus on women. So even more specific. We are in connection with a small association working there. They are called Line Verstice. They are Italian and Slovenese students from architecture, fine arts academy, and so on and so forth. And they work within this prison on these topics, and they work also on arts and on prescription since 5 to 6 years. So this is also another element I want to add. And now they have these 2 events related to the Biennale of Venice.
Very important indeed to know. And if you find the links, very happy to add them to the follow-up. I think also Niels and colleagues from WHO organized a very nice event recently this week as well, involving international artists and personalities. So I think that it's excellent to see that the movement is reaching as well the international stage. We're coming to.
If I'm not able, sorry, Michele, if I'm not able to find it now, I will share it with you by email.
Of course,
you,
yes.
Thank you.
We'll add and this as well for every speaker that participated. If you have something that you would like to share, we're going to have a really nice collection of slides. We have the recording, and we're going to publish everything on the Culture and Health platform website. And on this, I would just like to give the floor now to Cornelia, coordinator of the project, and of course, a big mastermind behind the connection between culture and health at European level. Cornelia, I'm really pleased with the event today. Just want to give a number before giving the floor to you. We had 232 registrations, basically equally split between the arts and culture and the health sector. So really nice that the two are coming together more and more. So really pleased on my side, and I hope you had the chance to enjoy the meeting as well, Cornelia. Floor is yours.
Yes, thank you very much. I'd like to just reiterate a couple of things from what was going in the chat and also in the discussions. Basically, there has been so many bottom-up initiatives for decades, actually, and what we really need now is a political will, and that's what we see, for example, in some of these regional examples, how Flanders or even Central Denmark region and also Greece has stepped up in this field. So only bottom-up doesn't work. We also need a top-down, bottom-up way. And for that, what we need to do also is to form networks and also on the health side. So please, whoever is here from the health side, do get together with like-minded people and step up and talk to your decision makers in the health side that this is something that we need now. And we are not asking to spend more money because we are, of course, understand everywhere there is budget cuts. But what we are asking is to spend it in a more clever way, in a way where there is more time for prevention of secondary diseases. So if there is already a disease, how, for example, additional depression and similar type of mental health disease could form from a health condition. And also we are asking for earlier action, much earlier action. We shouldn't wait until we go until the end. And with this, we could reach also even savings. And I have given a couple of examples, but also the examples in this meeting has shown how it actually can benefit long-term results in people's health and well-being. And also, for example, by returning to work and the social saving on that is also very beneficial, which needs to be monetized. So if we talk about moving from the biomedical model to a biopsychosocial model, we really need to act upon it. Mental health strategies come out, they talk about going back to communities, reduction of institutions, but nobody actually contacted the cultural sector, or in very few cases we have heard that going back to communities also means actually contacting the cultural sector in this field. Because there is a lot we can offer, and there is a huge potential in already existing systems and institutions. If we pair them together, there could be also a huge additional benefit. And the last thing that I saw in the chat is how a nurse was saying how actually artistic interventions also help the healthcare staff. So there is also a huge reduction in healthcare staff, and also their well-being is reducing. So also arts can help in this way. Also in a world where we have a digital shift ongoing, where human connections, live face-to-face connections are diminishing, and there is really a huge step that we need to take in order to a little bit counterbalance this aspect. I think I will give back the floor because the time is ending.
Thanks a lot, Cornelia, indeed. Thanks a lot also for gathering some of the bits and pieces that we had in chat. It was a very lively conversation there as well. A lot of link shares. So we'll do our best, of course, to capture everything. There will be the recording, the slides, which are, I think at least slide-wise, we're going to send them as soon as possible. For, of course, the report, we'll just ask you the time to put together everything and provide you with all the information that you need. Very pleased again that we managed to host these as Eureka together with the great help of all the speakers. I would like to thank again Niels, of course, for moderating as well the first part of the session, Nico, Singa, Stine, Annalise as well, of course, remotely, and clearly Kato, Ezio, Mikkel, and yourself, Cornelia, my colleagues, Angela, Marco, Sarah, Luca, and Martina that joined us today as well in the background. I hope I haven't forgotten anybody. If I did, I would like to thank all the participants as well. You made these very active and very engaging, so thanks a lot. I guess this is the second event that we organize as Eureka together with the Culture and Action Platform, Culture and Health Platform. It's not going to be the last one, definitely, and we're really looking forward to have more. Thanks a lot. Stay tuned in the different website of us, of the platform, and we hope to see you at the next event, maybe in person. Who's knows?
Thank you.
Thank you.
Thank you. Bye.
Thank you. Bye.
Bye bye. Thank you.